Thanks so much for that kind introduction. I'd like to thank Rashmi and the organizers for inviting me to speak to you all about this topic. These are my disclosures. Oops. So what I want to do in this lecture is talk a little bit, start with some history of aspects of NPM1 mutation and its involvement in myeloid malignancies, in particularly how it ushered in the concept that we now take for granted of a molecular lesion defining a disease entity. Also, we'll go through the role of NPM1 in the pathogenesis of AML and the significance of this mutation in AML and other myeloid neoplasms, in particular its prognostic significance, and also molecular heterogeneity within the group of NPM1 mutated myeloid malignancies, as well as heterogeneity in its morphologic and phenotypic presentation. And I'll sort of sprinkle through some cases to illustrate some challenges along the way. And then I'll end with a brief discussion of NPM1 as a marker of MRD in treated AML. So we all know AML is an aggressive hematopoietic neoplasm, and it's heralded by maturation arrest of the myeloid lineage, leading to the accumulation of blasts. And by accumulation, we define a somewhat arbitrary threshold of 20% that leads to the patients presenting with disease. It's quite a heterogeneous disease in terms of its clinical behavior, and this is probably due to a very varied mutational background. And it seems like mutations cooperate as a whole to create a hyperproliferative state and a state of impaired maturation of the malignant clone. The treatment is tailored generally based on the disease category or risk stratum, and as well as patient factors. So I think the way we've thought about AML diagnosis and classification has evolved over the years. In the 1980s, I would say the era was morphology, the French-American-British classification. By the way, the blasts appeared under the microscope. And then we began to use flow cytometry in the 1990s, and this is what I call the area of immunophenotype, where we phenotyped cases into their detail, as shown here. And then the era of cytogenetics, 2000s, when we began to associate, and even earlier, specific cytogenetic lesions with particular types of AML. And then finally, since around 2005, I would call the era of molecular genetics. Now, this doesn't by any means negate the prior. It's still important to consider morphology, immunophenotype, and cytogenetics as we think about AML and other diseases. But I would say this is when, in the more recent years, when the big explosion of information on molecular genetics in AML has come to the forefront. So let's start at where the topic of here is NPM1, and let's go back, go back in time to 2005, and this paper was published in the New England Journal by Bruno Fellini and colleagues that reported an unusual feature in a substantial subset, about 1/3 of AML. And Dr. Fellini's group noticed that this protein, they had an antibody to nucleophosphate, a nuclear cytoplasmic shuttling protein, and they noticed that it was abnormally dislocated to the cytoplasm, normally present in the nucleus, in about 1/3 of de novo AML cases. And this pattern was not present in other hematologic neoplasms like MDS or myeloproliferative neoplasms. And by doing sequencing, they noted that this abnormal localization was associated with a C-terminus mutation that was recurrent in the NPM1 gene that encoded the protein. Now, this was published in the New England Journal, and around this time, Nancy Harris, who was the editor of the New England Journal of Medicine case records, I was a junior faculty back then, and we published a CPC on the same issue, and it was a case we encountered at MGH of a woman who presented with leukemic meningitis, and in the end, we sent slides to Dr. Fellini, and he did the stain, and indeed, this is actually that case that showed cytoplasmic staining for the NPM1 protein. This was a case of NPM1 mutated AML diagnosed, and we presented this, and of course, there was a lot of interest in this new finding in a subset of AML. So back in 2005, we considered AML in different categories, mainly based on the history, whether it was therapy-related, if there was a lot of dysplasia we saw under the microscope. And there were some specific cytogenetic subgroups, but these were cytogenetic abnormalities. There was, as of yet, no mutation that defined any AML subgroups. So the question arises, around 2005, should NPM1 mutation be added to this group as a novel mutational defined entity? Again, now we take it for granted. 17 years ago, it wasn't so obvious. So this is the advisory committee 2 years later that met to consider this. This is when the 4th edition WHO was prepared. And I was a junior faculty member, and I was honored to be part of that group. Here's Bruno Fellini. Some of you may recognize some of the people here, Clara Bloomfield, Jim Vardaman, and many others. And so this was discussed and hotly debated, should this enter the group of AML alongside in version 16, 821, tried and tested subtypes. So pros are that the NPM1 mutation and cytogenic abnormality, cytoplasmic localization seem to be mutually exclusive. So it wasn't just a curiosity like, say, FLT3 that could occur across any AML subtype. It seemed to be exclusive with other known cytogenic subtypes of AML. There were also some positive biologic associations. The presence of an NPM1 cytoplasmic localization was correlated with CD34 negativity, a normal karyotype, often associated with FLT3 ITD that was already known about, and a suggestion at that time of a favorable prognosis. And this just shows the association of this cytoplasmic, as that was called back then, and AML with a normal karyotype as opposed to other AML, and also the fact that it was absent from all other known cytogenic subtypes of AML. But cons are that right now, mutational testing was not part of our armamentarium when a patient was diagnosed with AML. We looked at it under the microscope, we did flow, we grew a karyotype, but we didn't do any Sanger sequencing or anything like that. And the antibody that could be a surrogate for the mutation was not widely available. And to be honest with you, as I looked at this case we published as a CPC, it's not that easy to look for cytoplasmic dislocalization. There's a thick section, nucleus and cytoplasm may get blurred, so using the antibody as a abnormal localization of the protein wasn't always that easy either. It wasn't clear how this gave rise to a specific MDS subtype at the AML subtype, and there was no targeted therapy. So there was a lot of hot debate. And in the end, of course, as we all know, it did actually enter the classification as a provisional entity, shown here. This is how it was written in the 2008 classification, a year after that Chicago meeting. And what happened is, which I think is something that's very interesting, especially in all the very nice talks we heard about some new technologies like OGM and things like that, I think although there was some reluctance to introduce this because the technology wasn't yet there, what happened is the technology caught up with this disease. And eventually there was a penetration of interrogation of the NPM1 mutation. This became widespread over the ensuing years. After more cases were looked at, it became clear this was indeed associated with a favorable prognosis, and it was eventually elevated to a full-fledged entity in the next classification. So I think it's just an instructive, again, I don't always talk about history, but I think this is interesting to go back and see how this evolved and how the process that we now take for granted came to be. So now let's delve into the pathogenesis. Again, back in 2010, it wasn't that well understood, but how does the protein actually, how does this cytoplasmic translocation lead to AML? Well, this is, of course, as we all know, due to a heterozygous mutation in the gene in exon 12 that is a frame shift at the end of the gene that ends up removing a nuclear localization signal sequence that helps keep NPM1 in the nucleus and adds in a nuclear export signal. And as a result, the protein dislocates the cytoplasm. The consequences of this are not that well understood. It appears that this process leads to upregulation of a so-called stem cell-like signature. There's upregulation of Hox genes. The precise downstream mechanisms are uncertain, and it appears that in recent years there's some evidence that even though it locates to the cytoplasm, there's still some retained to the nucleus of the mutated protein, and this may actually bind to chromatin and affect gene transcription. So I think the precise mechanisms aren't that well known, but it may have to do with either pulling some nuclear proteins to the cytoplasm or binding certain proteins to the cytoplasm, the end effect being maintaining cells, arresting differentiation. We also know that NPM1 doesn't occur alone, but it actually cooperates with other mutations to arrest myeloid differentiation. It frequently arises in a background of clonal hematopoiesis, frequently with DNMT3A, TET2, and IDH mutations that affect DNA methylation and chromatin modification. And Dr. Fellini has referred to, who's written a lot about this type of AML, refers to it as the AML gatekeeper. The idea is that the mutation produces this neomorphic protein that then immediately arrests maturation and leads to very rapid and widespread accumulation of blasts. And this shows how this can happen on the backbone of an existing DNMT3A mutation Once the NPM1 develops, it arrests maturation, and often there are additional mutations like FLT3 that further drive the proliferation of the clone. So subsequent studies have also reinforced this, that NPM1 appears to define a major genetic subtype of primary AMLs. This is just a recent study that looked at, did unsupervised clustering of AML genomic signatures, which readily pulled out in this machine learning-based algorithm, immediately pulled out NPM1 as a distinct disease entity shown here. This disease group was essentially 100% NPM mutated, and it was associated in subsets with those cooperating mutations I told you about. We also know this NPM1 mutation seems to be stable over time. When NPM1 mutated AML patients relapse, they relapse with usually NPM1 mutated AML as well. This disease has a distinct gene expression profile. I mentioned upregulated homeobox genes, low CD34, low CD133, and also has a distinct RNA profile, implying it is a distinct tumor entity within AML. And this brings up the idea as we start thinking about the concepts of AML. There are two main pathways. This is a slide provided by Megan McNerney, who studies therapy-related AML, the sort of slow route to AML, if you will, often in elderly patients where there are multiple mutations that are honed over time, often under selection pressure of the host, often under stresses like therapy or aging or inflammation, giving rise to what we call a secondary type AML that's often genetically complex and resistant to therapy. NPM1 falls into the group, I think, of more genetically simple AMLs. Again, there are maybe some steps, but it seems to progress relatively rapidly, and it tends to be also lower risk, as I'll talk about later. So a genetically more simple type or so-called primary AML. So here's a typical example of NPM1 mutated AML. I'm a pathologist, so I like to show pictures, microscopic pictures. You can see this is a bone marrow. It's effaced by sheets of blast. There are essentially no maturing elements. That's often the case at diagnosis. And in the aspirate smear, or this is actually a blood smear of a patient with a very high white count, you can see the characteristic so-called cup-shaped blasts, which were described by several investigators when this was first initially described. It's a cup-shaped nuclear invagination that's often associated with NPM1 and or FLT mutated disease. There's also a morphologic correlate with this disease, the specific mutation. So what about its effect on prognosis? Well, all I've been talking to you about so far is biology, possible mechanisms, but what about, we're of course are interested in how this impacts patient care. Well, actually, it is associated with an overall favorable prognosis, but it's not as simple as initially it was thought because it depends on, again, the genetic background. So a study that came out by Schlenk et al. In 2008 showed that when NPM1 is mutated without FLT3 internal tandem duplication, so without this cooperating FLT3 gene, which drives hyperproliferation, the prognosis is quite good for AML, equivalent to another genetically defined entity, mutant CBPA AML. But then it's much worse in the presence of a FLT3 ITD mutation. And actually, clinically important for therapeutic management, many patients who have poor risk AML will undergo bone marrow transplant. And it turns out patients who don't have a FLT3 don't seem to benefit from a bone marrow transplant. That is randomized. Well, patients who have a donor that would automatically go to transplant versus those who didn't had a similar survival. Whereas if there was a FLT3, the patients were helped by transplant. So this led to the currently generally followed clinical management of patients who have an NPM mutation without a FLT3 ITD may not need a bone marrow transplant if they go into a remission. Although again, that depends on other factors like measurable residual disease. But it's again not even as simple as that because other more recent studies have shown that the context also depends, is more complex. So a FLT3 ITD without a DNMT3A cooperating mutation, a third mutation, may be very similar, but when there's a DNMT3A, that's what really gives the FLT3 its bad rap, if you will. So we're talking about multiple cooperation of multiple mutations with the NPM1 to really have it exert its prognostic impact on AML. And I think we're still learning about that as we go on. So this brings up the molecular heterogeneity of NPM1 mutated AML. So here you can see that in the circus plot, NPM1 is strongly associated with DNMT3A and FLT3 ITD particularly, but other FLT3 mutations, other RAS pathway mutations, IDH mutations. And it seems like it's the FLT3 ITD that seems to be the worst. In fact, other RAS pathway mutations may not be deleterious. We know that when it occurs with MDS-type cytogenetic aberrations like a complex karyotype, this is quite rare, but these definitely seem to overrule the NPM1 and give rise to an adverse prognosis. But I have in gray here some of the more controversial areas. In this last part of the talk, I'd like to now talk a little bit about, so far I've been telling you about the kind of nice crisp definition of NPM1 and how everything seems to fit well, favorable prognosis if there's no FLT3. But now let's get into a little bit of the more complexities. For example, what about other types of mutations that you maybe don't expect to see, like MDS-type mutations, and what about the variant allele frequency? So there's been some, this is a study that we published in collaboration or led by a group at Vanderbilt, and looking at these NPM1 mutated patients, and a subset, a minority, about 16% in our series, carried secondary or so-called MDS-associated mutations. These are mutations that usually occur in AML that progresses from MDS, and we don't expect to find those in the more de novo type NPM1 mutated AML. And in fact, there was a subset, and they had the typical genes we see, particularly SRSF2, ASXL1. These are gene mutations that are usually mutated in CMML or MDS. It turns out that although these are felt to confer an adverse prognosis in AML, when they occur together with NPM1, they don't seem to give an adverse prognosis. Now, this is a little bit controversial. There's some other studies that have shown that they may have confer a poor prognosis, but at least this relatively large study showed they may not. So again, the context of the gene mutation may matter in how the disease expresses itself in terms of its prognosis. This also shows, looking at variant allele frequency, it seems like when NPM1 occurs together with one of these MDS-type mutations, it's usually at a lower VAF, implying it's a sort of subclonal or secondary mutation on top of a pre-existing MDS-type mutation. So now let's look at a case that illustrates this phenomenon. Here's another case of NPM-mutated AML. This patient actually presented with a myeloid sarcoma. They did a bone marrow. His counts weren't too bad, but his marrow was actually totally replaced by blasts, which were CD117 positive, but CD34 negative, as is typical for NPM1 mutated disease. And this is a mutation-specific antibody now being used, showing the cytoplasmic protein localization. And these are genetic results. The patient had a normal karyotype, and you can see here there were more mutations than we usually see in NPM-mutated AML. There was a JAK2 at a relatively low VAF, FLT3 is expected, but there was this SRSF2 mutation that is an MDS-type mutation, and the NPM1 was at a lower VAF. And this implies a sequence of events where this SRSF2 was in a backbone. The NPM1 developed, that probably led to the AML, and the additional FLT3 probably drove additional hyperproliferation in the patient. So again, the NPM1 can occur in the background of existing mutations. Now, what about the NPM1 VAF? We did a study where we found that high NPM1 VAF, that is the highest quartile of the group that we looked at, which was a 43% VAF, predicted poor outcome. Now, again, this is a bit controversial. Other studies haven't replicated that. Some have shown some impact. We found that these were these were independent of co-mutations or blast percentage, so it wasn't just reflective of the disease burden. We also found that when this was present, it did correlate with subsequent MRD positivity, and this shows the survival curves, which are quite strikingly different. And this doesn't really make that much biologic sense if it doesn't reflect a blast count. One possibility is this may reflect the presence of multilineage involvement, that is NPM1 not only in the blast, but also in other cells. This shows NPM1 staining what look like erythroid elements, in this case of relapsing AML after therapy. And these cells here, these greenish yellow cells here, you can see represent NPM1 mutation in cells that are not blasts, so maturing cells. And so that implies that perhaps if there's a higher VAF, it may be that it's in a more primitive cell, perhaps it's more resistant to therapy, and that's seen by a higher VAF by spreading to other cell types that are not blasts. But again, this is all speculative. So what about other types of heterogeneity? Well, there's multilineage dysplasia. That's been recognized in about 30% of NPM-mutated AML, and studies done by us and others have shown, this shows in megakaryocytes, NPM1 mutation seems to have a higher frequency of megakaryocyte dysplasia, but this does not seem to have any influence on the prognosis, and generally we ignore dysplasia when we see it in NPM-mutated AML. There can also be variation in immunophenotype. We can see it sometimes in therapy-related disease, and it can sometimes progress from chronic myeloid neoplasm. So I just want to go through these somewhat more unusual presentations. So this is a study done, again, by Vanderbilt, showing that there is some immunophenotypic variability. In many cases, they're CD34 negative, but there's a subset that are also HLA-DR negative, which is so-called a promyelocytic leukemia-like or double negative phenotype, which makes up about a third of the NPM1 mutated cases. And we found, the Vanderbilt group found, that these cases seem to have a better prognosis. There was a strong association with cooperating TET2 and IDH mutations, but even in this genetic background, this particular phenotype seemed to confer a favorable prognosis. Again, suggesting that it may not be enough to just look at the mutations as a whole, but perhaps the differentiation stage of the blast may also provide additional information as to the prognosis or may color the prognosis of this particular AML subtype. Now, NPM1 is only rarely seen in association with therapy-related disease, and its implications are uncertain. Traditionally, therapy-related was thought to be the worst type of AML, but a recent study done by Bruno Fellini, again, and colleagues, just published this year, showed that the survival was actually the same when they accumulated enough cases. Therapy-related NPM1 mutated AML, that is, NPM mutated AML occurring after patients whose marrow was exposed to cytotoxic agents, seems to have a similar prognosis to de novo NPM-mutated AML and much better than other therapy-related disease. And this is important because the new classifications, both the ICC and the WHO, now kind of make therapy-related sort of a qualifier. So we still will express the NPM1 in our diagnosis and add on therapy-related or post-cytotoxic therapy, implying recognizing the importance of the NPM1, that it may not be unfavorable even if the patient has had prior cytotoxic therapy. There are also some cases of MDS-CML and MDS-MPNs that can progress to AML by acquiring an NPM1 mutation. Again, this is relatively infrequent. The idea is that there might be just as we know that NPM1 can occur in a background of clonal hematopoiesis, there may be a so-called MDS prodrome where the patient actually presents with cytopenia and then comes to clinical attention and then later gets the NPM1. This is actually not very frequent. It seems like the NPM1, once it happens, it really drives a very rapid increase in blasts, but occasionally there are cases that are reported. So then the question becomes, what happens if we do find an NPM1 mutation in patients who have less than 20% blasts that have traditionally defined AML? And this is a studies done by Sanjay Patel and colleagues, as well as a group at MD Anderson, and both were published sort of back-to-back or within a few months of each other in Blood Advances, and both had similar conclusions that indeed NPM1 could occur in a subset of pre-AML myeloid neoplasms, if you will, and they had actually very similar genetic features to NPM-mutated AML and had a much worse prognosis than other MDS, implying very aggressive behavior. And the MD Anderson group showed very provocatively that patients who did get actually induction chemotherapy, the numbers are small, and others were treated as if they were AML, despite not having enough blasts, actually had a better prognosis, implying you might be able to rescue these patients. So now we're beginning to think that patients can present with a lower blast count, and rather than just calling them MDS, perhaps they should be regarded as AML. And in fact, this is exactly what the new classifications have done, now allowing the diagnosis of AML with these lower blast counts in the setting of an NPM1 mutation. This is a review done by, or a study done by Bruno Fellini recently that compared these NPM-mutated MDSs and showed the similarities that they do in fact have with AML. Whereas the blasts in most MDSs are CD34 positive, like their AML counterparts in low blast MDS, they're 34 negative, the karyotype is similar, the cooperating mutations are similar, except there are some differences, notably usually lack of FLT3 in the MDS presentations, and also a lower white count. And that's not surprising because these are what will drive a very high blast count and probably drive the marrow getting overtaken with blasts. In the interest of time, I just want to go to the last few cases here, a couple cases, to illustrate some of these difficult cases. This is a man who presented with, pancytopenia. You can see looking at this marrow, the pathologist in the audience might think this is a myeloproliferative neoplasm. The patient had pancytopenia, though, no circulating blasts. The patient had high reticulin fibrosis, which unfortunately caused dry tap. There was no obvious increase in blasts. So the question is this primary myelofibrosis? Well, lo and behold, the NPM1 immunostain was positive, and there was an NPM1 mutation detected. So this chronic myeloid neoplasm appearing case actually did have an NPM1 mutation. So this is a case I would sound descriptively. The patient died within a couple weeks, that was unable to be treated with intensive therapy, but perhaps the patient may have benefited from being treated with cytotoxic therapy as if they had AML. Then finally, what about deeply subclonal NPM1 mutations? This is another unusual case. An older woman, NPM1 usually occurs in somewhat younger patients. This is an 82-year-old woman who presented with some circulating blasts, but pancytopenia. The marrow had CD34 positive blasts. There are just sheets of blasts here. But only a few were actually NPM1 mutated, and this was borne out in the NGS, showing a very low VAF. Now, there's no VAF cutoff to define NPM1. This is just barely above the validated threshold. Is this the same as a patient who has, full-fledged NPM1? If you look at the other mutations, it looks like a typical MDS case or maybe an MDS-MPN. So again, I think these are still unanswered questions. Should this patient be considered? Probably not be considered with a typical NPM1 mutated AML. So just in the last minute, I just want to talk about as a marker of MRD. We know that persistent NPM1 mutation predicts poor outcome following stem cell transplant. This is typically done by either RT-qPCR, digital droplet, or some sensitive method. The thing that's still open is whether these patients can be rescued by additional therapy if they have MRD. Nevertheless, the ELN guidelines do recommend assessing for NPM1 MRD after treatment, and these are the typical time points, and this shows the adverse effect of MRD positivity prior to undergoing stem cell transplant in the setting of NPM1 mutation positivity. However, the presence of other mutations may not necessarily signify a bad disease or an MRD. Remember, true MRD is persistence of the NPM1. If you have persistence of DNMT3A or one of these background mutations, this does not necessarily confer an adverse prognosis. So it's important to look at what mutation is actually positive before calling MRD. And NPM1 is considered to be AML defining, and it's a true marker of MRD in this setting. So in conclusion, classic NPM1 mutated AML represents a distinct and a relatively homogeneous entity characterized by a high blast count, CD34 negativity, and cup-like blast morphology, and generally has a favorable prognosis if there's no FLT3-ITD. But the long-term outcome is highly dependent on the eradication of the clone in the absence of MRD. Less common scenarios, though, still require further study. For example, cases with low blasts, I showed you some examples of that, subcloning mutations, or secondarily acquired mutations. These may not have the same favorable prognosis, and I think require further study. I didn't have a chance to get into therapy, but there are some new menin inhibitor therapies. NPM1 is thought to perhaps interact with MLL and menin in the nucleus, and that's why menin inhibitors may be effective against this, and there are now trials, and this is now exciting, but as of yet, there's no NPM1 specific target. So with that, I'll thank you for your attention, and if there's time, take any questions.
Thank you for what a wonderful talk. You touched on it on like the second to last slide, and this is something that I have a problem with, where our pathologists are sending out, our heme pathologists are sending out for NPM1 MRD when, I'm doing the NGS in the background and I'm seeing PTPN11, TET2, IDH, and yes, NPM1 might be 1%, but the PTPN11 is sitting at 20%. What is your feeling about maybe there's a subset that you send out for MRD with that specific in mind, or is it really fine to just know that it's NPM1 negative or low level?
Yeah, I think that's a good question. I think we need more information to know what the significance of background mutations are. I think some are not necessarily ominous, for example, DNMT3A, perhaps even IDH in the background. But there's a publication published from the Haferlot group showing that they talk about clonal hematopoiesis of oncogenic potential. So other mutations, including like PTPN11, may be more likely to progress to a relapse state. So I think I don't think clinicians would necessarily act on that, but right now the only approved marker of MRD is the NPM1. We're supposed to kind of ignore those other mutations, although it's hard to, but those are not considered to be equivalent to MRD as of yet. But I think further study is needed for sure.
Thank you. It was a great talk. Thank you.
Thank you.
Thank you for a wonderful presentation. Would you care to speculate on the potential utility of single-cell genomics, transcriptomics in AML? Do you feel that we as clinical directors have that in our near future, or do you think a lot more work has to be done yet?
I think that's a great question. I think single cell is the next, another horizon, and I think it does provide helpful information. I think eventually we'll get there, and it provides useful information. Knowing the clonal complexity, we can infer things, but if you have 2 clones at VAF of 5%, you don't know if they're in the same cells or not. I think that's still right now in the research setting. I think when it goes into the clinical arena, I think that'll be really helpful, but I think right now we're definitely not there yet.
Thanks.
Should I answer that question, or there's something on the screen? Or I guess you want to go?
Yes, there's a question on the screen. When it comes to NPM1 variants, are the mutations generally the same? Or are there some VUS NPM1s?
Yeah, that's an interesting question. I think most of them are in exon 12, and there's that 4 base pair insertion. There are some variants that usually give rise to the same. As long as they essentially cause cytoplasmic export, they should be equivalent. I'm not aware if there are any NPM1 VAFs, VOSs. I'd have to ask my molecular colleagues. I'm not aware of them, but I think most of the variant mutations have the same essentially effect on the protein, and then they would be considered to be generally equivalent.
Great presentation for early career people here. I have a question about the graphs that you had for the NP high, NPM1 low with the survival curve. Have you seen any splicing events that are conserved among patients that are mutation-free that might justify the difference in survival?
You mean splicing mutations? You mean additional splicing mutations in those patients that have high VAF?
Correct. High versus low, like sub categories that have splicing events within the low.
Oh, within the NPM1 gene, you mean?
Yeah.
Oh, I see what you mean. That might affect. We didn't actually look at that, so that's an interesting question. I'm not aware that that could be a cause of that, so we didn't actually look at that specifically.
If there is no mutation,
That's
might be with a
interesting.
splicing event. It would be
That's
good to
interesting.
look
Yeah.
at.
We didn't find any association with other co-mutations, but we didn't look specifically for splicing. Yeah.
I think for the sake of time, we need to move on to session 2, advances in cancer informatics. Thank you, Dr. Hasserjian.